Yeah, I'm Dr. Dinesh. I'm a community medicine graduate working in ICMR VCRC as scientist B. So basically today I'll be mainly I'll be dealing with the clinical features, diagnosis and management of lymphatic filariasis. So the plan of presentation will be, I'll be briefly discussing the background. I suppose Dr. Sarvesan sir has already covered most of the things. We'll be looking at in brief about what is the current global and Indian scenario, what is the burden, and mainly we'll be concentrating on the clinical features, diagnosis, and management. So, as you all know, lymphatic filariasis is a neglected tropical disease which is caused by nematode worms, Filariasis bancrofti and Brugia species, basically Brugia malayi and Brugia timori. In India, it's most commonly the Filariasis bancrofti, which is found, which is more common here. And this is transmitted by mosquitoes, most commonly by Equinox fasciatus, and Brugia by Mansonia species. And to some extent, Anopheles and Aedes are also involved in the transmission of the disease. So basically, this disease damages the lymphatic system, which ultimately results in lymphedema and hydrocele. It is quite disfiguring and debilitating disease. WHO has ranked it as one of the leading cause of permanent and long-term disability globally. Hence, this disease is also, it was twice actually targeted for elimination in 2015 and 20, and twice it got deferred. And now the latest target is for the year 2030. So basically, lymphatic filariasis is a social evil because the disfigurement of the limb and genitalia, it often leads to stigma, anxiety, psychological trauma, and sexual dysfunction. Okay, the disease also impedes mobility, travel, educational, and employment opportunities, and marriage prospects of individuals, and it also results in economic loss and poverty. And no wonder there has been, we have fixed a target for elimination for this disease. So moving on to the current burden of the disease. So first, let's see what is the global scenario. So according to WHO, 72 countries in the tropics and subtropics of Asia, Africa, Western Pacific, Caribbean, and South America. Okay, the disease is quite endemic in these regions. If we take the Sierra region, that is Southeast Asia region alone, which constitutes around 9 countries, the major burden of the disease is concentrated in this region. And India contributes around more than 40% of the global burden of lymphatic filariasis. The global baseline estimate for hydrocele is around 25 million cases, and lymphedema is around 15 million cases. As of 2019, WHO reports that nearly 859 million people in 50 countries are threatened and require preventive chemotherapy. And of these 50 countries, 10 countries, mass drug administration has never been delivered. And 17 countries and territories have already achieved elimination, and MDA has been stopped in these countries. And 5 countries are under post-MDA surveillance. Moving on to the Indian scenario. So on the left side, you see the scenario in 2004. In 2004, nearly 600 million people were at risk of developing lymphatic filariasis, and there were around 256 endemic districts in 2004. The current burden, which is unpublished data. So according to the current data, nearly 670 million people are at risk, which constitutes to nearly more than 40% of the global burden. And the disease is spread over 328 endemic districts in 16 states and 4 union territories. And the population with overt disease manifestation is around 0.64 million. And lymphedema, as on 2020, which is the provisional data, is around 0.49 million, and hydrocele is around 0.15 million. So moving on to the clinical features. So as we all know, filariasis ultimately results in, either it can be the form of 2 manifestations. One is mainly because of the parasite, okay, which is present in the lymphatic system. The other presentation could be because of immune hyperresponsiveness of the human host to the filarial antigen. Okay, so because of the parasite as such, the manifestation is called as lymphatic filariasis. This can present itself as asymptomatic, acute, or a chronic presentation. The other one is called as occult filariasis, which is basically due to immune hyperresponsiveness of the human host to the filarial antigen. And the most common example is your tropical pulmonary eosinophilia. So moving on to the clinical features of lymphatic filariasis. So it can present itself as asymptomatic A microfilariemia, or it's otherwise called as endemic normal. So what is this endemic normal? So basically in endemic areas, it is common to find people who do not have any microfilaria in their blood, and they may not be having any clinical signs or symptoms. Even though they are exposed, they may not be having any microfilaria, nor they may not be having any visible symptoms or signs. So they are called as asymptomatic. That is called as the stage of asymptomatic amicrofilaria. Okay. After that, in the early stages, people will have the MF microfilaria in blood, or even at times adult form may be present. But however, they may not be symptomatic. They may not show any signs or symptoms of lymphatic filariasis. This is a stage of asymptomatic microfilaria, or this usually occurs in the early stages. Okay, so we saw about endemic normal, then we saw about asymptomatic microfilaria, which is usually in the early stages. Okay, so wherein the MF will be present, the worm may be present, but however, the person will not have any clinical signs or symptoms of filariasis. Okay, other than this, there could be also recurrent episodes of acute inflammation of the lymph glands and vessels. This can present either in the form of fever, lymphangitis, which is basically involvement of the vessels, lymph vessels, or lymphadenitis, wherein the nodes are involved, or it can present itself as ADLA, which is nothing but acute dermatolymphangioadenitis. So wherein the skin is also involved, the lymphatic system is involved, the vessels, glands, so everything is involved. Okay. Then we can also present as lymphedema and epidermal orchitis in men, okay, which is inflammation of the epidermis and the male sexual organs. And chronic manifestation usually occurs because of fibrosis and lymphatic damage, and this usually occurs nearly 10 to 15 years after the onset of initial clinical symptoms. And this can present itself as either as hydrocele or elephantiasis. Elephantiasis can be most commonly it affects the leg. At times it can be seen in the scrotum, arm, penis, vulva, and breast. And the pyluria is also one of the sign which can occur in chronic filariasis, and this is quite rare. Pyluria is nothing but passing lymph fluid in urine. So, what is lymphedema and elephantiasis? So, as I said initially, basically lymphedema occurs because of dilatation of the lymphatic vessels. Okay, ultimately the lymphatic vessel system is totally damaged. So ultimately this results in stasis of the lymphatic fluid. So as stasis ensues, what happens is there is exudation of the fluid, which ultimately results in lymphedema. Okay, and these lymphedema, it usually progresses because there are superadded bacterial and fungal infection. So there are recurrent attacks of either ADLA, or because of these recurrent secondary bacterial infection or fungal infection, the lymphedema progresses, and ultimately over years it progresses to something called as elephantiasis. Okay, so basically lymphedema usually commonly involves the lower limb only, and mostly it is unilateral. There is only one limb can be involved, and sometimes it can be bilateral, and mostly it will be an asymptomatic involvement of the limbs. Upper limb, male genitalia, and also breast are also involved at times. So moving on to the grading of lymphedema. So according to WHO, there are 4 grades of lymphedema. So grade 1 is nothing but pitting lymphedema. So grade 1 is pitting edema, and the edema will be reversible on elevation of the limb. Grade 2 is it can be a pitting or non-pitting edema, and usually the edema is non-reversible. That is, even on elevation of the limb, the edema will not reduce. The swelling will be there. Okay. And also one more thing is there won't be any sort of skin involvement in grade 2. Grade 3 is non-pitting edema, and the swelling will be non-reversible. In spite of doing a limb elevation, there won't be any, the swelling will not reduce at all. Okay, and this stage will be showing thickening of the skin. And grade 4 is non-pitting edema, which is non-reversible, and thickening of skin along with nodular or warty lesions will be seen. This usually is called as a stage of elephantiasis. Okay, as it further progresses in advanced stages, you'll be seeing multiple skin folds. The skin folds can be deep or shallow. There will be hypertrichosis, black pigmentation. There will be warty lesions, mossy growths. Okay, then in between these there will be fungal infection between the skin folds, or usually also often because if the limb is not kept clean, secondary bacterial infections can occur. And intertrigo is commonly seen in the web spaces of the toes, and non-healing chronic ulcers can also occur in advanced stages. So most of these patients, they usually they just ignore the hygiene of the limb. So often they are exposed to secondary bacterial infections or fungal infection, and these usually act as entry points. I mean, your any open wounds or any ulcers or anything, they act as open wound, and ultimately, when these infection occurs, what happens? It results in aggravation of. It results in ADLA attacks. So ADLA attack will again progress your lymphedema, and ultimately, the lymph size also increases with each attack of ADLA. So let's see about acute dermatolymphangioadenitis, which is nothing but ADLA. Okay, so these are actually acute inflammatory episodes, which are usually associated with fever, chills, headache, pain, and vomiting due to secondary bacterial or fungal infection. So basically, these infections occur through entry points. As I already told, it can be through the interdigital spaces, or it can be because of some injury, or it could be because of dryness of skin and cracks which are developing on the skin, or because of fissures. And in severe cases, they may also present with toxemia, with altered sensorium, and urinary incontinence. And this is more frequently seen in higher grades of lymphedema. The affected area during ADLA is extremely painful, warm, red, swollen, and tender. The person is totally incapacitated. He is not able to move around. And also, red streaks may be visible along the inflamed lymphatic vessels. Also, the patient will be complaining of swollen lymph nodes, which are very painful as well, especially in the groin area and the axillary region. The clinical presentation will be in the form of lymphangitis, lymphadenitis, cellulitis, or abscess. So, as I already told, frequent attacks of ADLA, what happens? It increases the progression of lymphedema, ultimately results in development of elephantiasis. So, hydrocele is another presentation of lymphatic filariasis, and it's most commonly seen in men. Usually, it is uncommon in childhood, but frequently seen post-puberty period, and the prevalence increases with the age of the individual. And the adult worm usually have a preference for the scrotal lymphatics or the lymphatics of the spermatic cord. This can be easily viewed by means of ultrasonography. And basically, what happens is there will be proliferation of the lymphatic endothelium and transudation of the hydrocele fluid in the scrotal lymphatics. And because of localization of the worm in the lymphatics of spermatic cord, the cord will be thickened, and there will be dilatation of cord vessels, so the spermatic cords becomes palpable. Okay, so at times the hydrocele can be very massive. It may or may not present with lymphedema. Okay, so so far we discussed about lymphatic filariasis presentation because of presence of worm in the body. The next thing is because of occult, something called as occult filariasis, which is due to hyperresponsiveness, immune hyperresponsiveness. Okay, the condition is called as tropical pulmonary eosinophilia. The person usually presents with respiratory symptoms like cough, breathlessness, wheezing, or chest pain, and these symptoms are mostly reported nocturnally. And systemic symptoms are also maybe the person may present with systemic symptoms such as fever, weight loss, fatigue, and malaise. Extrapulmonary symptoms are lymphadenopathy, hepatosplenomegaly. Signs we can look for wheeze and crackles. And on blood examination, there will be massive eosinophilia of more than 3,000 microns. It can go up to 80,000 microns. The erythrocyte sedimentation rate will often be elevated. It will be more than 90%. High serum levels of IgE, filaria-specific IgE and IgG will usually be seen in this condition. And if you look at the blood, microfilaria is usually absent. So moving on to the diagnosis. So diagnosis is basically the most important thing for diagnosing the case of lymphatic filariasis is a detailed history of the evolution of disease and clinical examination. So when you get a detailed history and clinical examination, when the person acquired the infection, okay, when he started developing the swelling, when he notices swelling, all those things, okay, it will easily help you to rule out the other primary causes of lymphedema and secondary causes of lymphedema. So primary causes of lymphedema such as congenital anomalies of lymphatics, usually they will be present from after birth. And secondary lymphedema will be following some malignancy or some irradiation, or it could be because of some surgical excision of a lymph node, or podoconiosis is actually because of Usually it's seen because of volcanic areas, because of the red clay soil, wherein because of the soil acts as an irritant and can result in, it can mimic lymphatic filariasis, but however it is not because of MF. Okay, so other diagnoses are basically we just look for microfilaria, we look for circulating filarial antigen, or we look for antibodies to specific antigens to specific antigens, antibodies to specific filarial antigens like WB123 or BM14. So the most commonly used is your night blood smear. So basically, we collect the blood smear nearly around 60 microliters using a capillary tube. So usually we collect it only after 8:30 p.m. because the microfilaria is seen in the blood only in the night time. Because of the peak of high biting rate during the night. So usually night blood smears are collected in the night after 8:30 p.m. Only limitation of night blood smear is that it is quite labor intensive because the blood has to be collected in the night, and most of the time people will be sleeping and they will not be willing to give their bloods. Other than that, slide preparation, staining, and microscopy is also all these are manual, so it's quite tedious. So this is one of the diagnostic means. The second thing is using circulatory filarial antigens. So currently we are using Filariasis test strip since 2013. Earlier to this we are using immunochromatographic card test, and before that ELISA was used. So now commonly we use a rapid diagnostic test kit, which is basically by Aleve. It's called as Filariasis test strip. So basically it has actually a marker for the adult female worm. One thing about this thing is that the antigen clearance is much slower and compared to MF clearance. So even after giving treatment, people can still remain positive for antigen. But another advantage is that you need not go for MF testing for everyone. Night blood smears need not be collected from everyone. We can do the antigen testing in the daytime. So whichever individual who are positive for circulating filarial antigen, for those people, you can go for the night blood smears. So usually we collect around, a simple finger prick method. We collect around 75 microliters of blood using a micropipette. And this is a port and this is a filariasis strip. So what we do, we just drop the blood over this part of the strip. And after that, we just note the time and we have to wait for 10 minutes. So if only one single line is seen, then that is a control line, then it is going to be negative. If two lines, that is, this is a control line and this is a test line. Okay. So if both the lines are seen, then it is called as a positive test. And based on the intensity of the color, okay, we just grade them as grade 1, 2, 3. Okay, strongly positive, medium positive, and mild positive. Okay, if the test line is going to be very mild in color when compared to the control line, in that case it is mild positive. If both the test line and control line are of the same color, it is called as medium positive. And if the test line is going to be very strong in color and compared to the control line, it is called as strong positive. Okay. So other thing is based on antibody. So basically we have we have ELISA test to antibodies against specific filarial antigens, which are WB123 and BM14. So one good thing about these antibody tests is that they are more sensitive when compared to the antigen-based test, basically to detect ongoing transmission or exposure in young children. However, again, this again has the same limitation, that is slow clearance. That is, in spite of giving treatment, the person can still remain positive for antibody. And also, the antibody-based tests are quite expensive. Okay, now in case of a person who is already infected, so this picture shows, the ultrasonography is another means by which you can diagnose the person with lymphatic filariasis. So this is actually, this picture shows the ultrasonography of the scrotum. So wherein we locate the, it's called as filarial dance sign. So the adult worms are usually localized in the lymphatics of the scrotal sac. So and usually they are usually visible under ultrasonography. So another test is lymphoscintigraphy, wherein we inject the radioisotope dye between the interdigital spaces, and we just observe the uptake of the dye over a period of time. So actually, this picture shows that the uptake of dye is good on the right lower limb, whereas the left lower limb is completely complete obstruction is there. And even the delayed lymphoscintigraphy which has been taken, it shows uptake of the dye on the right side, which is so it shows that on the right limb the lymphatic system is intact, whereas in the left limb there is obstruction. So because there is no movement of, when we saw about lymphoscintigraphy, is another method to basically assess the structural and functional changes in the lymphatics. So this also we saw. Okay, another thing is frequent measurement of the limb volume and the limb circumference. Basically, this is to assess the progression of lymphedema. So this is also another means by which you can know. This is basically for mostly for the prognostic aspect. So that's about the diagnosis. Then we move to the management. So basically, the global program to eliminate lymphatic filariasis, it has two pillars. So the first pillar is preventive chemotherapy through annual MDA, basically to interrupt transmission. The other one is morbidity management and disability prevention, which is also called as MMDP. So this is basically for those people who are already infected and they are presenting with symptoms with lymphedema or elephantiasis. So the first pillar, that is mass drug administration. The basic goal of MDA was to reduce the density of parasite circulating in the blood of infected person, and thereby the prevalence of infection in the community to level where the transmission is no longer sustainable by the mosquito vector. So basically, three drugs are being used. So one was diethylcarbamazine (DEC). The dose is around 6 milligram per kilogram. Then albendazole around 400 milligram, and ivermectin. The dose is 200 microgram per kg. So initially, we are using a combination of two drug combination, that is DEC and albendazole. And in areas where onchocerciasis was prevalent, DEC, instead of DEC, ivermectin and albendazole were given, and in case of lower LOA, only albendazole was given. So DEC actually we usually it's not given to pregnant women, chronically ill, and children less than 2 years. And in case of ivermectin, it's the same, but only thing is we cannot give it to children less than 5 years. And also, the use of DEC in the late stages is quite not indicated because it is not going to reverse the lymphatic damage which has already occurred. And it is also not going to be useful during the ADLA attacks or in the chronic advanced stages of lymphedema. So currently in India, 153 districts are under mass drug administration. And nearly 132 districts have already, MD has been stopped, and they are in various levels of TAS. So recently, in India we have introduced from two-drug regimen. Two-drug regimen was introduced in the year 2004, and of late in 2019, we have started giving three-drug regimen. Three-drug regimen basically which includes all the three drugs. That is DEC, albendazole, and ivermectin. So these were actually based on several studies which were conducted in the world. So, which are the randomized controlled trials with single dose of triple drug, that is IDA. It showed that IDA clears microfilaria in over 90% of MF positives, and it was maintained over a period of 5 years. And also another multicentric safety and efficacy trial, it demonstrated the superiority of triple drug regimen over two-drug regimen, wherein it showed 90% clearance of MF after single dose of IDA. So other than that, even transmission-based modeling studies also showed that MDA with triple drug regimen require fewer rounds, that is around 2 to 3 rounds with effective coverage of 65% in order to achieve elimination threshold, that is MF prevalence less than 1%. Whereas in case of two drug regimen, usually we go for 5 to 6 rounds of MDA with a minimum coverage of 65%. So Government of India endorsed WHO recommendation to use IDA during MDA in order to accelerate LF elimination in the year 2018. And currently, three-drug regimen during MDA is being implemented in 21 districts in 6 states. So moving on to the treatment of ADLA. So if it is going to be a mild case of ADLA, usually we advise for bed rest. Complete bed rest. The patient should not do any sort of physical activity because it can aggravate this. And ADLA attacks are very painful that the person is totally incapacitated. So bed rest is advised to all patients with ADLA, and elevation of the affected limb and symptomatic treatment is usually given. Usually, we give paracetamol. And any local precipitating entry lesions like any injury or any intertrigo or any cuts or cracks or fissures. Okay, all these things are usually treated with some local antibiotic or antifungal ointments. In case of moderate to severe ADLA, okay, we go for oral or parenteral administration of antibiotics along with some analgesics or anti-inflammatory agents. Antibiotics normally we give penicillin group of drugs or doxycycline, ampicillin, amoxicillin, quatermoxazole is usually given. And if you go for a bacteriological examination of the swab, so it might be helpful in choosing the right antibiotic in severe cases. So other ways to prevent ADLA is basically by a simple mean. That is, the patient should be advised to go for a proper foot care. So foot hygiene is very, very important in order to prevent ADLA, and that way, if you're going to prevent ADLA attacks, okay, the progression of lymphedema also can be prevented, and ultimately, the morbid conditions of elephantiasis, wherein the patient becomes totally immobile, can be prevented. So basically, the foot care program usually consists of washing the affected area, especially the interdigital region and deep skin folds, with soap and water twice a day or at least once before going to bed, and wiping dry with a clean cloth. And usually, you should not use, the patient should be advised not to use hot water. It should be normal plain water. And other thing is clipping of the nails at regular intervals and keeping them clean is very, very important. And also treating any local injury or infection using antibiotic or antifungal ointments, especially the web spaces, skin folds, and sides of feet in order to prevent fungal infection. And also the patient should be advised to wear a comfortable footwear. Okay, so all these should be, the person once diagnosed with lymphatic filariasis, he should be advised to follow a proper foot care from the early stages, so that any future attacks of ADLA can be prevented, and thereby he can the development of lymphedema, progression of lymphedema can be arrested. So these pictures shows the washing techniques which are usually which is being currently practiced in the filariasis clinic in VCRC. So we just teach the patient regarding how to wash the limb. Usually, we wash from top to bottom. Washing, and see to that we ensure that the patient wash their the toe web spaces, adequately. We advise them to go for clipping of the nails. Limb elevation is usually advised. So other than that, the treatment for lymphedema, we advise them to use cream bandage or stockings, during the daytime, and nighttime they are usually asked to remove them. Limb elevation is quite important. Then regular exercises of the affected limb has to be carried over. Other than this, we also teach them to regularly massage the limb, so that this stimulates the lymphatics and helps to improves the flow of lymph to the larger patent vessels. Other than this, we also have we advise for intermittent pneumatic compression of the affected limb, either using a single or multi-cell jacket. So these usually what they do, this also promotes better drainage of the lymphatic fluid. And for morbid conditions where people are not able to move because of elephantiasis limb, surgical procedures are also being done. But however, one important disadvantage is that the recurrence rate is quite high even after the surgical procedure. And basically, this is mainly because the patient usually, even after surgery, they will not, be very careful regarding the limb hygiene. So always it is very, very important that foot care hygiene is very important, and patients should be advised that we have to advise the patient to maintain, the hygiene of their foot always. So these pictures shows, the cream bandage and stockings which are usually advised, and this picture shows, a person who's doing self massage to improve the lymphatic drainage. So that's it. Thank you.